Good morning, everyone. I'm pleased to say I did see some good dancing this morning. That is a good start, people. We've got all day, though. I see improvement from some required. Can you please take a seat and get yourself comfy? And once again, welcome. Thank you so much for joining us for the first ever Remote Australians Matter conference. We're so excited to have you here, and after how well things kicked off last night, we can't wait for today. I'm going to hand over to Annabelle Brayley, the Chair of Remote Australians Matter, to welcome you this morning. So, Annabelle, let's give her a big clap.
Thanks, and good morning. Firstly, I'd like to pay my respect to the Bidjara people and all Aboriginal and Torres Strait Islander people in the room, particularly the emerging leaders, one of whom I know is definitely here. I'd also like to pay my respect to everyone in this room and those joining us virtually. Together we're all Australian, and together we can make change. I'd like to extend a warm welcome to everyone who joined us this morning, either here in the room for the first time or virtually. And just getting housekeeping out of the way first of all, and I actually don't know how to do housekeeping, so I'm going to tell you the toilets are out there, and if there's a fire, the doors are there, go out there. Please remember there are cash-only tickets floating around, and I'd like to thank everyone who donated to the wonderful prizes that we have. There are five draws for your $5, or multiples of $5, just saying. And finally, could you all please see the registration team to confirm your presence at dinner tonight? For all of you watching virtually, we understand there was a slight hiccup in transmission last night, which makes this the perfect opportunity to thank the tech team, Nev Dolinsky from Outback Sound in Blackall, and Aaron Skin from Satisfaction Photographs in Bark-Alden for orchestrating all of the technology involved in delivering this conference and for so quickly reconnecting virtual viewers last night. Wendy will share an overview of last night's proceedings directly, but before we do that, I'd like to explain the recent changes to our program timing. As you know, we've been planning this conference for some months. As it's an Australia-wide forum, we invited every federal politician and senator, plus many state ministers and politicians who have had any connection to health and/or remote Australia, including, of course, the health minister. All of the apologies are on the notice board outside for your interest. Some replied, some carrier pigeons apparently dropped their messages. I'd particularly like to thank and welcome Senator Susan McDonald, Federal Shadow Minister for Northern Australia, who committed to be at this conference right from the moment she received her invitation. I'd also like to welcome the Honourable Rob Mulhern, LNP member for Southport. Rob currently serves on the Health and Environment Committee here in Queensland. About 3 weeks ago, the Federal Minister for Health, Mark Butler, having declined our invitation, called a meeting in Canberra to discuss primary health care and invited specific people to attend today. The first on his list was the National Rural Health Commissioner, Professor Ruth Stewart, who was to be here in Charleville. Unable to decline the invitation from her direct boss, Professor Stewart pre-recorded her address, which you'll see shortly. 13 days ago, the Minister invited Professor Sabina Knight, Director of JCU's Murtapuni Centre for Rural and Remote Health, Dr Megan Bello, President of the Rural Doctors Association of Australia, and Dr Dan Halliday, President of Australian College of Rural and Remote Medicine, to attend that meeting, all of them panellists on our program. Needless to say, we have enormous respect for their decision to come to Charleville first, but it means that they must fly out this afternoon. Consequently, 12 days ago, we began the process of rescheduling that has enabled us to make the most of the 24 hours everyone is on the ground. Later this morning, we're going to begin the process of establishing the working groups we hope you'll all be keen to be members of moving forward. We obviously have a number of influencers in the room, from CEOs of two of our most successful Aboriginal and Torres Strait Islander community health services to the ED Executive Director of RFDS Australia. Most importantly, we have all of you rural and remote Australians. Sorry, you remote and very remote Australians, because as I keep saying to the media, remote gets lost in the rural health context, so we're focusing on remote. All of those of you who are going to help us drive this campaign to focus attention on remote Australia, establish a minimum standard of primary health care, and participate in the design and development of models that deliver appropriate PHC options into your particular communities. Unless otherwise advised, all of you will be embedded into one of the 5 working groups I mentioned a moment ago. You will have contact details for everyone in the room, so that going forward, if you're working to improve the access you and your community have to primary health care, you will have direct email contact with anyone you think can help. Certainly all of us, the RAM directors, but also all of these influencers who have joined us. Better yet, they'll have direct access to you. This can and should be a two-way street. As remote Australians, you will be able to inform them what's happening in your part of Australia. We have hard copy contact sheets for each of you with a space to add phone numbers and addresses for anyone caring to share, and they'll be given out to you when we start the working groups. This startup has the potential to make real change if we all get involved and we all work together. So we encourage you to encourage everyone you know to get involved and keep working together. That said, let's get this show on the road.
Thanks, Annabelle. What a ripping start to the morning. So now we're all revved up and ready to go. That's fantastic. I'd like to acknowledge that we're meeting today on Bidjara land and pay my respect to elders past and present, and extend that respect to any other Aboriginal or Torres Strait Islander people in the room as well. So what did we do last night? It's been interesting to have conversations with people as I've wandered around this morning, and I've heard lots of different versions. So I've pulled together a bit of a summary from what I heard. So those of you who weren't here, you missed a cracking start. So we had Dr. Sarah Renwick-Lau from Malakuta Medical Centre give us an example of a model that works, a place-based model that works, and it was so inspiring. I could almost move there, except it's in very remote Victoria, which I just can't get my head around, and nor can the people in Melbourne, apparently. That's part of the issue. So... And the summary would be, it's amazing the things that are possible when you give the power to the people. So there's a shared vision in that community for making GPs sustainable. And what they've done in Malakuta is engage and empower the community with shared ownership and shared decision making. So they wanted to keep those health services in their town, and they now own that issue themselves. So they formed a fund with DGR status. They then bought the surgery from the GPs so that they could have a better business model. They started a targeted and innovative recruitment strategy, which has been incredibly successful. They've supported Sarah to change her business model, which must have been really hard because she stopped delivering essential non-GP services that they had been delivering for a long time. And Sarah networked more, and she found critical advisors that have been with her on the journey and made a massive difference. So thank you, Sarah. It was so exciting. Today we've got 2 more models to be shared with you from very different parts of Australia. We then had the panel, what are the health needs of remote communities? And we had Gillian Fennell from South Australia, June Counsellor from Western Australia, Michael Bishop and Dr. Michael Clements from Queensland, and Dr. Megan Below from Victoria. And I'll start with a quote from Megan. We need to bring sexy back to GPs. There's a challenge for the Health Committee. So the issues that came up were people want consistent, coordinated services, holistic care, and people able to have relationships with the people they get the care from. and that need access to care when they need it. Gillian pointed out that in her area, acute and proactive health are served well, but the challenge is in the middle of the road. Then another key point was around recruitment and retention, which of course is no surprise to anyone. June's point was in Western Australia, in remote Western Australia, they've learnt that they really have to build their talent from within. And they've also done a lot of work on the importance of self-care because burnout is a real issue. Megan talked a lot about the importance of active succession planning, and I had a conversation yesterday on the plane that this is actually a national conversation. And she pointed out that it has to be across the whole supply chain so that everyone is planning and the training is matching the needs. And she pointed out that only 13% of young medical students are actually choosing to be a GP. But it'll be more when being a GP is sexy, Megan, so it's okay. So funding issues, that funding creates silos and that there needs to be a flexibility of the models that communities are able to use. Michael Clements talked about accountability is needed because currently health outcomes are not a KPI. And Michael Bishop talked about a lot of things, but one of them that struck a chord with a few other people in the audience was about bureaucracy and how it gets in the way of doing the work. And an example he gave was, I think he said in the Northern Territory, 6 people had to sign off on a role before it could be filled. And by then, if we talk about a thin workforce, they've got a job somewhere else. So that's my summary from last night. I'd be keen to hear any of your thoughts, and if I missed anything, you're welcome to let me know. And let's get started on today. So Annabelle's talked about the purpose of RAM and given us a really good kickstart. Today, and there is programs outside if you're someone who likes to have one in your hot little hand. We're going to hear from 2 more of the existing successful models, and we're going to be introduced to another group of Australia's key medical influencers in a panel. And then, as Annabelle said, we're going into the working groups to work on solutions. And the goal of that is to find the 5 priority areas for RAMS to advocate and action moving forward. And the bit that she didn't mention, surprisingly, is that the board of RAMS are also looking to build on their diversity and skills pool by seeking nominations today from people who'd be interested in being in a committee to work alongside the RAMS board moving forward. Now, before we start the day with our really special guest appearance from Canberra with our now virtual keynote address from the adjunct Professor Ruth Stewart, I'd just like to get us moving, get us started. I don't think there was enough dancing when we came on in. So we're going to do a quick stand-up. So I'd like you to stand up if you travelled more than 4 hours to get here for this conference. Excellent. Thank you so much. We really do appreciate that. It is hard to get here. Which is also sort of the point. So thank you so much. So sitting down. Stand up if you've ever used the services of the Flying Doctor or another evacuation service. Wow. Wow, that's huge. So, thank you. That might explain some of your commitment to being here as well. Stand up if you work for the Flying Doctors. Take a bow. Thank you. No, thank you very much. And we have one of our panellists later is one of the Flying Doctor people, so no doubt we'll get some more insight. Stand up if you can access a nurse any day of the week. Excellent. Thank you. Sitting down. Stand up if you can access a doctor any day of the week. Stay standing if you live in a remote area and you can access a doctor any day of the week. Wow, okay, thank you. And just one last one, and this actually is the most important one. Stand up if the Broncos are going to win this weekend. I'm disappointed with this crowd. Sitting down, stand up if the Lions are going to win this weekend. What? They'll be delighted that they had 3 fans in Charleville. We're all slowly being converted, Sabrina. Okay, so now, as Annabelle said, unfortunately, Adjunct Professor Ruth Stewart couldn't make it today, but she has pre-recorded her keynote address for us. Some of you will already know Ruth. For those of you who don't, she's been a rural generalist with advanced skills in obstetrics for over 30 years, working clinically in private practice, rural hospitals and clinicals in southwest Victoria and far north Queensland. She has extensive experience as a director within the health and training sectors, and notably she spent 12 years as a board member and is a past president of the Australian College of Rural and Remote Medicine. So she's joining us today to share more about her role with the National Rural Health as the National Rural Health Commissioner, to share ideas on model of care and to share the results of a recent consensus report, amongst other things. So even though unfortunately we haven't got her here in person, we're really excited and honoured that she's committed to this and done this pre-recorded presentation. So it will come up now, ready to go. Thank you.
I'm Ruth Stewart, the National Rural Health Commissioner. I'm very glad to be able to speak to you today. I just wish I was there in person. I would much rather be in Charleville than in Canberra, but needs must. So there I am. Now, I've prepared a PowerPoint presentation which I would like to talk to, and so let's begin. I'll just bear with me while I bring that up. Here we go. So I'm going to talk to you today about remote people and their health and the fact that you matter a lot. And I'd like to begin by acknowledging the traditional custodians of the lands where you are meeting today, the lands of the Bidjara people. I pay my respects to the Bidjara elders past and present, and I'd also like to acknowledge emerging leaders within the community. I extend my respect to all Aboriginal and Torres Strait Islander people here today. Today I will talk to you about the Office of the National Rural Health Commissioner, rural and remote Australians and their health, primary care, what it is and what it can do, the Nayaba Gadan Consensus Statement on rural and remote multidisciplinary healthcare teams, and models of care. So let's start. First of all, my role as the National Rural Health Commissioner. I work to a statement of expectations, which you can find online, published on the website for my office. This is contained in a letter that is written to me by the Minister for Regional Health, and it outlines the activity I'm to undertake during my term. I will save you the bother of reading that and summarise it, but you're most welcome to go and read the original document. I'm to support urgent and emerging priorities, such as the COVID-19 pandemic and our response to it, I'm to contribute to the implementation of innovative models of care. I think that you might agree that one of the reasons why we struggle to find the workforce that we need in rural and remote Australia is that we have models of care that were designed for major cities and not for rural and remote communities. So they're difficult to work in, uncomfortable, and they're not sustainable. People leave. I'm to support First Nations people's health and well-being, and particularly to support efforts and activity to increase First Nations people's participation in the health workforce. I'm to contribute to rural workforce training and primary care reform. Now, I summarise that as the rural generalism, and I'm sure you'll be talking a lot about that today. And I'm to build strong stakeholder relationships. Okay. I am assisted very ably by two excellent Deputy Rural Health Commissioners, Faye McMillan, who has expertise in allied health. Faye was Australia's first Indigenous pharmacist. She's a very proud Wiradjuri, and Shelley Nolan, Deputy Commissioner for Nursing and Midwifery. Shelley's other gig is as the Chief Nurse and Midwifery Officer for Queensland Health. So their role is to support me in achieving the goals of the office and to provide expert advice in their particular disciplines. Now, they do this by engaging with rural, regional and remote stakeholder groups from their professions. And we meet regularly to go through what they're doing, what the issues are. They give me advice, I give them advice, on it goes. So let's start talking now about health conditions and their prevalence in Australians, and particularly what the health of remote Australians is. I've drawn this data from the Australian Institute of Health and Welfare report from 2023. Let's look at the incidence of smoking. Now this bar chart shows the incidence of current daily smoking, and as the colour changes from pale to darker green, you go from major cities to inner regional to outer regional and remote communities. The top three bars are for males, the middle three bars are for females, and that is all gathered together as a total for both male and female, all persons, on the bottom rung. So, rural and remote people smoke more than their urban counterparts. Smoking is a causative factor in many, many chronic diseases. We can start by talking about chronic obstructive pulmonary disease, coronary vascular disease, cerebrovascular disease, renal failure, and peripheral vascular disease, cancers of the lung, cancers of the esophagus, cancers of the mouth. If any of you are smokers, please stop, please, for your sake, for the sake of your family who love you. Okay, let's also look at the prevalence of daily sugary drink consumption. Now, I always look at sugary drinks as empty calories. They make you fat without giving you very much nutrition at all. The more remote you go in Australia, the more likely you are to consume sugary drinks on a daily basis. It's interesting to see that men really drink far more sugary drinks than women do. And in fact, when you're looking at it, men in major cities drink about as much sugary drinks as remote women do. But generally, the important thing is to note that it increases as you go more remote. So, health condition prevalence in Australians. This data is also from the Australian Institute of Health and Welfare, and who reported that rural and remote Australians have poorer health outcomes than the metropolitan populations. They have a higher rate of arthritis, asthma and diabetes, and higher rates of hospitalisation. Like, this is the serious stuff. Hospitalisation, deaths, injury. But despite that, have poorer access to and use of primary healthcare services than their metropolitan counterparts. Doesn't make sense, does it? So let's think about First Nations Australians. First Nations Australians living in major cities generally live 6 years longer than First Nations Australians living in remote and very remote areas. So the poorer health outcomes that you have as a First Nations Australian are compounded by living remotely. First Nations Australians are also disproportionately represented in the statistics for acute rheumatic fever and for rheumatic heart disease. In fact, they have 81% of the diagnoses of those two diseases are amongst First Nations Australians. I can't call it a crime, but it's a disgrace on us as a nation. And that, look, the highest incidence of acute rheumatic fever and rheumatic heart disease occur in Darwin, which isn't a remote community, but also in East Arnhem Land and in Alice Springs, two remote communities. Let's think about First Nations people and eye health. This is actually looking at Indigenous Australians aged 40 and over, and how many of them suffer from vision loss. So as we move from the left of this graph to the right, we're going from major cities, inner regional, outer regional, remote and very remote. The dark blue is a point estimate for Indigenous Australians, and the yellowy orange colour is for non-Indigenous. What you can see by looking at this is that Indigenous Australians have a higher percentage of vision loss in every region, but the highest rates of vision loss occur amongst Indigenous Australians in outer regional and very remote. But you can see in the remote that there's a very wide confidence interval, which is probably demonstrating that there are studies that have been done where there's been some really good work done and the outcomes are better. And there are studies done where there's been not very much work at all and the outcomes are really poor. But I'll just point out again, very remote community, it makes a big difference whether you are Indigenous or non-Indigenous. And this must surely relate to how appropriate and safe culturally the health services are for Indigenous Australians. Because if the, and it may also reflect the socioeconomic status of individuals, but those two combined things mean that Indigenous, very remote dwelling Australians have very poor rates of vision loss. Okay. So I said I was going to talk to you about primary care. Why do I need to talk about it? So I'm going to give you this quote from Barbara Starfield and colleagues from a very significant paper in 2000, published in 2005, in which they found that a greater emphasis on primary care can be expected to lower the cost of care, to improve health through access to more appropriate services, and to reduce the inequities in the population's health. So this study that was published in 2005 found that where there was good investment in primary health care, the health outcomes for the rich and the poor, the affluent, the people with power and the people who with relatively less power, the inequity is reduced. The health of the two groups is much closer. So what is primary care? If it has this impact, what is it? Well, the World Health Organization has given us a very fulsome definition. Primary health care is essential health care based on practical, scientifically sound and socially acceptable methods and technology made universally accessible to individuals and families in the community through their full participation and at a cost that the community and country can afford to maintain at every stage of their development, in the spirit of self-reliance and self-determination. As I said, it's quite a fulsome definition, so I found it very helpful to use this, which is the Department of Health and Aged Care's definition of primary care. It's healthcare people seek first in their community, such as general practitioners, pharmacies, and allied health professionals. There you go. So let's think about this, how to improve access to primary care. We need a greater emphasis on primary care to lower the cost of care. So we need to prioritise investment in and support primary care. We need to prioritise investment in and support generalist health workforces with pipelines to careers in primary care. So that's turning away from concentration on specialisation. And to reduce those inequities in the population's health, we need to prioritise access to primary care to reduce the disease burden and improve communities' health. So the patient experience in outer regional and remote areas, more people waiting longer to see GPs for urgent medical care. This is from the Australian Bureau of Statistics. Rural and remote people are more likely to wait for more than 24 hours to see a GP for urgent medical care. That's 49.5% of us in remote communities compared with 35.5% in major cities. We report waiting longer than is felt acceptable for a GP appointment, 28% compared with 21% in the major cities. And we delay appointments with dental professionals. This is really significant. That's 25% of us delay appointments compared with only 10% in major cities. And we also do that for GP care. That's 5% compared with 3.5%. That difference is a little bit less, but you know. Okay, so let's have a look at these, the distribution of health professionals per 100,000. So let's just the colours here. It's a nice colourful graph, isn't it? Major cities are in that bright green, pale blue is inner regional, yellow is outer regional, the darker green is remote, and the teal blue is very remote. So you can see that there's a steady decline from major cities to outer regional, but there's a bit of a blip here in remote and very remote. That is reflected in the numbers of nurses and midwives. And since they are the most prevalent workforce, particularly in rural and remote, it's no surprise that that influences the totals that we see. Now you can see that allied health professionals diminish significantly as you go from urban to remote. Negligibly small numbers of dentists in very remote communities. Medical practitioners steadily decline, but there's a bit of a blip there for remote, which probably represents fly in, fly out, not full-time live-in services. So now it's time to talk about this work from my office that I'm very proud of, the Ngaya Barkadan Consensus Statement on Rural and Remote Multidisciplinary Health Teams. Ngaya Barkadan means coming together in the Yidinji language. We held the Ngaya Barkadan Summit in Cairns, and Yidinji are the traditional custodians, and they gifted us this title for both the summit and the consensus statement that grew out of that. So it provides a statement and definition for use in policy, funding and model of care design for rural and remote communities. And it defines system enablers that allow them to establish, thrive and deliver high-quality place-based care. And we'll go into some of the details of it. There was an absolute emphasis on the importance of First Nations. An essential element is ensuring Aboriginal and Torres Strait Islander people and communities and organisations are represented in policy development, in leadership roles, as fund holders, as organisational leaders, co-design with community, and by working and training in rural and remote multidisciplinary teams. If we want to improve the health of First Nations Australians, we must hear their voices in our health systems, and we must facilitate their full participation in the delivery of healthcare. So I'm just going to pick out one of the themes from the statement, the system enabler of person and community context. This recognises that communities need to be involved in service co-design for the multidisciplinary teams to deliver best outcomes for the community. And successful and meaningful co-design must have comprehensive representation of the full diversity of the community, not just the loudest voices, not just the most powerful sectors of the community, but all sectors of the community should be represented in the design of the health service for the community. The Department of Health, under the direction of the Minister for Regional Health, has been doing a lot of work in innovative models of care. This was something that was begun with the previous government and has been continued by the current government. This recognises that health models should be co-designed by local communities and health services. We started with the primary care rural innovative multidisciplinary models. When I started in this role, one of my first jobs was to work with the department to set up a grant opportunity to enable communities to develop models of care, and that emphasised the multidisciplinary nature and was specific for their own environment. So it talked about new ways of working together These models are delivered by locally based multidisciplinary teams and supported by visiting specialists. And we know that these teams are sustainable and safe and viable in rural and remote communities. The Innovative Models of Care grant opportunities continue. There's, I think it's round 5 is just about to be announced. And there are a wonderful variety right across the nation of innovative models of care. People are thinking about new ways to deliver care that the community wants. So there you go. Thank you very much. And I hope that your talks today are really engaging and that you absolutely commit to thinking about how things can be done better for the people of rural, but I know this is actually remote Australia. Thank you. And goodbye.
What a pity that Ruth isn't actually here with us. I'm sure you've all got a million questions to ask her, and maybe we can set up a Q&A with her virtually following this forum. So, gosh, I was writing notes and I was taking photos, and I've actually left my phone down there, but there was so many key points there. Thank you. I couldn't keep up with her, but the beauty of slides is that I could just take photos. And I thought some of the key points that I took from that primary care, a greater emphasis on primary care can be expected to lower the costs of care, improve health through access to more appropriate services, and reduce the inequities in population health. And they're not so easy to give us the solutions. Her thoughts are that we prioritise our investments in support of primary care, that we prioritise investments in and support generalist health workforces with pipelines to careers in primary care, and that we prioritise access to primary care that can reduce, so prioritising access to primary care can reduce disease burden and improve the community's health. Those points tie back so much to the conversation that the panel had last night and the points that you raised. And another couple of things I took from her, the Niobe-Gaydon consensus statement really reinforced what June said to us last night. In June's statement last night relating to the need to include, encourage and hear the voices of the First Nations people in all our service delivery. And the last point from Ruth, that models of care need to be co-designed, place-based and appropriate. Also, that panel last night knew what they were talking about. Well done. No, it was fabulous reinforcement, and I'm sure there might have been some more points there that were new, and maybe we can set up a virtual Q&A with her because she was very sad to not be here. So now I've been waiting to hear from June after her presentation yesterday. June flew and travelled for over 20 hours to get from Western Australia to here, and we're really grateful and excited to have you here, June. She's going to be talking to us about the remote healthcare model that they've developed at Port Hedland, and she has actually been the CEO of Wirakamaya Health Service Aboriginal Corporation, located on Kariyara land in Port Hedland, South Hedland, West Australia for 11 years now. She brings incredible broad experience from working in the not-for-profit and state government sectors in remote Western Australia, including education and training, Aboriginal health, child protection, community development, social justice, policy and law reform, research, FASD and the Child Death Review team at Ombudsman WA. Combining this incredible professional knowledge and experience with her passion to empower others to achieve their goals and her tireless commitment to improve health outcomes for Aboriginal and Torres Strait Islander people creates a really powerful foundation for her work at Wirakamaya and we really look forward to hearing more about it now, June. So I'm going to get June to step up here and share this successful local model and inspire us, no doubt. Thanks, June.
Thanks, Wendy, for that. Okay, thanks very much. Can I pull it down, or is it? Can you hear me okay? Pull it down? Okay, thank you. I want to first of all acknowledge the traditional owners of the country that I'm standing on today. Is it the Bidjara people? And pay my respects to the elders, the past, the present and the emerging. I've got a presentation, I'm hoping that you can see it on the screen. So I've got to learn to drive. Okay, so I also want to thank the Remote Australia Matters for the invitation to present today. I'm so excited to be here, and thank you so much for this opportunity to meet so many wonderful people who are working with us in the health sector and with the same passion, and more so remotely, because I come from a very remote community, and that's in the centre of my heart. I want to also acknowledge the Aboriginal and Torres Strait Islander people of this country, of this area and the surrounding communities, and the local Aboriginal and Torres Strait Islander Health Service, and it was really wonderful to meet Cheryl, and I know that I can learn a lot from her. She's been in the game a lot longer than I, so I'll certainly take some tips from her. Who am I? I'm a Bunjima woman. I've also got ties to the Ngarluma and the Yinjibarndi and the Newbally communities in the Pilbara region. So was born in the Pilbara, born in Port Hedland, grew up in Marble Bar. So a lot of you may have heard of Marble Bar being the hottest place in the world. Well, that's very true. And I think Marble Bar still holds the record of being 50 degrees. Over 100 years they've held that record and still continue to hold it. So this is just a picture of my family, my mum and dad, who I love very dearly. My dad I lost at the age of 46, so he had a very short life, but he influenced and had an impact on a lot of people over that time, including all of his 11 children. Down the bottom is my little family, my children and grandchildren, and the latest addition is my little grandson, who's 6 weeks old now. So, thank you. So, these are the people that drive me to for the passion that I have to make a difference in people's lives. So I work with the Wirrakamai Health Service Aboriginal Corporation. We're located in South Hedland in the Pilbara region. We're an Aboriginal community controlled health service, so we get government funding to provide our services. We're registered with ORIC, and so we have the accountability to our members. So we have a membership of 260 people, so that's the membership of the corporation, and we're governed by a board of directors. Just to give you an idea of where we are, so Port Hedland is over on the north part of the coast of Western Australia, and I've just marked Charleville, so that's the distance that we are between Port Hedland and Charleville. And on the, what's on my right side on my screen, there's 8 regions in WA, so you'll see the smaller map that breaks down the regions of Western Australia, and the pink is the Pilbara region, so we go right out to the Northern Territory border. This is just a breakdown of the Aboriginal health services in the Pilbara region, so there's 3 Aboriginal community-controlled health services. So we provide a service in Port Hedland, then we've got Murrungutta Health Service who provides a service around the Roban area, and then Punta Cuna Aboriginal Medical Service based in Newman that covers the Western Desert area. So this just gives you an idea of the reach for the Aboriginal medical services. So as our patch is the smallest, we are the smallest AMS, so you can see how remote we have to go. I mean, even though our AMS is probably considered a bit more rural rather, or I don't know. We're not remote because we're on the coast, and so we get the ships coming in, we can get services and everything, but when you have a look at Punta Cuna and how far they have to go, they're more remote than us. So you'll see that there's a bit of an overlap. So these are boundaries. These are invisible boundaries that the respect of the Aboriginal community-controlled health sector has for each other and our patches. So there is a overlap, so you'll see Nullagine where the, on the map there. So even though that's more meant to be covered by us, we have an arrangement with Punta Cana Aboriginal Medical Service to cover that community because it's mostly Māori people that live in that community, and PAMS is the one, or Punta Cana is the one that covers all of the Māori communities. So I also mentioned that, I just mentioned that we're based in South Hedland, but we provide services to Port Hedland as well, Warralong community, Yandiara community, Marble Bar, Strelly and other surrounding communities. These are our board of directors. So we have, in our rule book, we have a maximum of 8 directors, but we have 7 of those seats filled at the moment. And then we have to have a minimum of 5, so we'll always have to have 5 directors. And these are elected at our AGM by our corporation members. So Rowena Brown down on the bottom, she is the daughter of our founding member. So Wirrakamai was founded by the passion of her dad, Mr. Lennis Brown, and I have permission to use his name even though he's passed, to set up an Aboriginal hospital in Port Hedland. So he knew about other Aboriginal medical services from Carnarvon and other places, and he came home and he wanted to get some funding from government to build a Aboriginal, what they call Aboriginal hospital, which is what they refer to us as. And that was 30 years ago, and unfortunately he didn't live long enough to see the fruits of it, but his daughter has come onto our board to continue his legacy. This is just our organisational structure, so we have the board of directors, the CEO, and then the chief operating officer, and then under that we have all our senior managers, and then under the senior managers we have coordinators of programs, and then all of the staff. So that's just a picture of our units within our organisation. So we are a member of NACCHO. I'm not sure if most of you might know who the National Aboriginal Community Controlled Health Organisation is. So that's the national peak body. We're also a member of the state affiliate, which is Aboriginal Health Council of WA. And then within the region, the Pilbara region, the 3 AMSs got together and established the Pilbara Aboriginal Health Alliance, because as individual AMSs, it was very difficult for us to have a voice. We're only a very small region compared to, say, the Kimberley, and so we found that we weren't getting anywhere or any attention from government. So the 3 boards of the 3 AMSs got together with the 3 CEOs, and we talked about what is it that we can do to build the strength of our individual AMSs, but also find the strength for our region, because we know that a lot of our people are transient and they go through the region and even up into the Kimberley or down into the Gascoyne and so on. So our board came up with the idea of establishing an alliance, and that's in 2019 they came together, so that was where it was first established. So, and besides the membership that we have with those 3 organisations, we are also very actively involved with the Pilbara Aboriginal Health Alliance, the Pilbara Aboriginal Health Planning Forum, which isn't an incorporated body, but it's all of the health professionals, all of the health organisations that have a responsibility for Aboriginal health in the Pilbara region come together on an 8-week, every 2 months. And we sit at the table and we discuss the priority areas for the region. And that includes the Commonwealth Government, the state government, the PAHA, and Royal Flying Doctor Service, WA Country Health, the WA Primary Health Alliance. So all of the players in health come together to talk about what's happening in our region, what are some of our priorities, what are some of the issues that we need to address, and how we're going to address that. And under that planning forum, we've got specialist committees like your chronic disease, your child and maternal health, your men's group, And so we draw on the expertise in the region from the health services who come together to talk about that, and then they feed that up into the Aboriginal Health Planning Forum. Just going on a little bit about Wirrakamaya now. So we have over 5,000 registered clients. 88% of those are Indigenous or of Aboriginal and Torres Strait Islander descent, and 12% is non-Indigenous. Now, we have we welcome non-Indigenous people because we recognise that cross-cultural marriages is important and we don't want to leave anybody out. But we also recognise that there's a lot of non-Aboriginal people in our community who may not be able to afford to go to a GP, to a private practice. So we provide services to them as well, and we don't like to turn anyone away. So what we have also, when we look at our workforce, we've got 52 staff at the moment, and I think there's 48 of those positions that are filled. 80% are female, and a majority, again, are of Aboriginal and Torres Strait Islander background. So 44% is of our workers work in the clinic, 21% in the wellbeing centre, and 19% in admin, and then 16% in NDIS. So we have looked at we did quite a lot of work with the legal team around bringing all of our employment contracts into compliance with legislation. And so what we've found was that there's 5 different awards that our service have to comply with for each one of those professions. So when you've got your doctors and your registrars, specialists and interns, they come under the medical award. You know, Aboriginal and Torres Strait Islanders, workers and admin and corporate all comes in under the ATSI Community Controlled Award. And then we've got the Nurses Award for the nurses. The health professionals and support, which is our SEWB counsellors and support workers and pharmacists, come under that award. And then we've got the Social Community Home Care and Disability Services Industry Award, which covers our NDIS workers. So that's a lot of awards that we needed to get our employment contracts it was quite a body of work because we had employment contracts everywhere and people were really not sure. Now they know that they are covered under that award. We had to negotiate with the staff that were already employed with the service and get them to agree to come in and sign new contracts, which meant that they didn't lose anything. So they were not disadvantaged in any way. They were actually in a better position to be able to negotiate under their awards. So we have 10 different funders for our service. Our biggest funder is at Commonwealth under the IHP program. So they provide us with money for the primary health care, maternal and child health, and continuous quality improvement. And then we've got NDIA, who gives us a little bit of money for one counsellor and an advocate, and that came out of the Bringing Them Home report. But they want this amount of data and information for this amount of money that they give us. Which is sad because you would expect that, you know, the NIA would be the ones that would really want to be, you know, topping up Aboriginal services. But anyway, then we've got the WA Country Health Service provides us also with funding for primary health care. We've got Mental Health Commission. This is new funding. So the Mental Health Commission came to us and wanted to give us some money, and we said, no, we don't really need any more money. We've got enough money under the SEWB, and the reason for that was because we just don't have any space. We're really working on top of each other at the moment, so we couldn't really take on anything more. But what I was able to negotiate with them for is we've got funding and we've got support and resources for individuals who have mental health conditions or psychosocial conditions. But what we don't have is anything for the families who are looking after the loved ones at home and finding it difficult to access services or, take their loved ones into supports. So we got that funding now to provide supports for the family, because that's that holistic care, because no one was looking after the families who were looking after their loved ones who are unwell. So then we get funding from NACHO, AQUA, WAFA, we get some funding from WAFA. Rural Health West, we get specialist funding from them to do outreach. And the PAHA has also given us some money, and PAMS. So Wirukmai currently holds accreditation with AgPal, recently just in the last couple of months with NDIS, so we're now a registered NDIS provider. The Training Accreditation Council is for our RTO. APRA, so all of our Aboriginal health practitioners are registered with APRA, so they do their qualification through the RTO, then they do their, I think it's 500 hours of clinical supervision work in the clinic, and then they can apply for registration. And then the Quality Improvements Performance, which is the accreditation that is across the whole organisation. Oh, sorry, and then we're also now just waiting for the mental health accreditation to come out, because we'll go for that as well. The other area that we don't do at the moment that we want to do and should do but can't do is aged care. So this is just a picture of the top is our social emotional wellbeing, and the bottom is our clinic buildings. So we have a clinic building, we have a social emotional wellbeing building, we've got an admin donga up the back. We've just recently bought another donga for our COVID and our chronic disease team. And then we've got our tackling Indigenous smoking. So there's about 5 buildings on our site, and we have been we've got a building expansion project that we've been working on for the last 11, 12 years, and we haven't been able to get any funding for a building that could actually expand our services. And so we've just had to be really innovative and look at other ways of still doing business, still taking on to meet the needs of our community, and doing it differently. So Wirukmai, we're just coming towards the end of our strategic plan, our 5-year plan. So the way that we did the plan was they met with the board, they met with the staff, they met with the senior managers, they went out to community, because we got independent consultants to do it for us. And then they also worked with our stakeholders to build what it is that Wirukmai should and could be doing for the community to improve the health outcomes for our people. And so they came up with the 4 priority areas or strategic themes around health, workforce and leadership, infrastructure and financial sustainability. And what we do now, and what we've done with our plan, is that we've embedded all of our values: respect, integrity, leadership, innovation, customer service and teamwork. That's what we built into our strategic plan. We build it into everything that we do. We have awards for staff that is focused on where they've demonstrated any part of that value, and then they get, we celebrate that with a staff lunch, and then they get an award and a voucher to show that, we really do mean business, because we want to provide a high level service to our Aboriginal and Torres Strait Islander people, which they so deserve. So we've got the strategic plan, which is the overarching plan, and then under that comes our action plan. So that's our Bible, if you like, that our workers have to look at and where they fit under, if it's clinic, if it's wellbeing, if it's NDIS, and we've built COVID in there as well. So that gives them the step-by-step plan of what they need to do, and that's what they have to report against then. So our clinical services, we provide primary health care, maternal and child health, sexual health, chronic disease, COVID screening and vaccinations, and we're still doing that because we're still getting positive cases in our community. Partnerships, we're really big on partnerships because we can't do everything. We're not the be-all and end-all, even though we'd like to be. We want to be the one-stop shop, but we can't do that without partnerships and without research, because we need to prove that what we're doing is working. And then we've got a mobile clinic that we go out to community events as well. Now, I've got some of the staff up there, and these are the ones that have been our longer-serving staff members. So Skip, the man up on the top, he's been with us for 21 years. He's our one Aboriginal and Torres Strait Islander health practitioner, but he's also a qualified mental health worker as well. So dual qualified, and he's like a gem in our organisation because he has to do go out to law camps to work with men and for that cultural stuff. Helen's been with us for nearly 20 years. And then we've got workers in there who've started just in programs, delivering programs, who've now worked their way up and become very strong and empowering their clients. And so we saw signs of leadership. So they've been encouraged to, act in the managers' roles. And we've got a couple of them now who are actually permanently employed in senior managers' roles. So our SEWB program, we've got our Transition to Adulthood. Now that's a state-funded program for our at-risk kids and our kids who have risk-taking behaviour. So they do a lot of work around resilience and building up their self-esteem and stuff like that. And that's all done through interactive activities, basketball, fishing, whatever it might be. Tackling Indigenous smoking, that's a very successful program as well. We do counselling, advocacy and mental health, which is just a really broad description of what we're doing in there. So we were elected as one of the 5 pilot sites for a SEWB program that was funded through Mental Health Commission. The funding was given to ACWA, which is the state body, and they picked 5 sites across WA to run a 3-year program. And so we were between the 3 AMSs, it was agreed that Wirrakamai was in the best position to be able to pick up that program and run with it. So we're doing that, and so we're really grateful to be able to have access now to a psychologist. We tried for a number of months to advertise for a psychologist, and we didn't get any hits. So what we've done is we purchased a private psychologist to come up and do on-site visits and do telehealth as well. So that's been working really well in the last 6 months, and we'll continue to do that to the end of the year. Tell me when I'm running out of time, because I can talk. Sorry. Getting dry. So our social emotional wellbeing and our mental health programs, we don't see them as social emotional wellbeing, health, mental health, tackling Indigenous. We see it as social emotional wellbeing. So it doesn't matter which program you're in, you belong to that SEWB team, and what the client sees is just the faces that they need to see. They don't know, who funds what and who reports to who. We want to make it a really seamless process for our patients, because they are the focus of our organisation. So we have all of those programs working together. Our NDIS we've had to put off-site, but they actually work also, still come and work really closely with our SEWB program. And then we have the clinic, and what we try to do is gel those two together as well through internal referral pathways. And so that the client, if they're coming in to see a GP and the GP recognise that they need to see the counsellor or the psychologist, they do that referral across to SEWB, and then the other way as well. If they come in to do counselling and they can see that there's something that's then off their medication or there's something that's not right, then they'll refer them to the GP. So we're trying to do a real seamless process for our clients so that they can get the best level of care. So this is our NDIS team. So they do a wonderful job. And so we've got what we see is sort of 3 areas, or the funding covers 3 areas where we've got the NDIS coordinator. And at the moment we're only doing support coordination, but now that we're accredited and once we get our certificate, because that should be happening anytime soon, we've got formal proof that we've passed it. We're just waiting for the certificate, and then we'll go into core supports. But we've got the remote community connector funding that was given to us through NDIA, and then we've got the NPSM, which is our psychosocial funding, which was the old FAMS funding that they dissolved when NDIS started. So the psychosocial support worker is the one that will support those who aren't eligible for NDIS but still need that high level of support. So we're a registered training organisation. So at the moment we've only got 1 course on scope, and so we just don't get funding. We've been self-funding that, and so we don't have any workers in the RTO. But there's so much potential for this organisation, for us to be able to keep that RTO happening in our region, because once it's lost out of our region, it'll be very difficult for us to get it back. So we've been trying to knock on the Commonwealth door to say, look, we need funding for our RTO, because that's where we can build our workforce in health, and we can expand the courses on scope as well, so we can go even further. Okay, that's just staff harmony. So we celebrate everything. We celebrate, because we have a multicultural workforce, so we celebrate all of the different cultures as well. These are some of our photos of our kids' programs, our NAIDOC events. So we do the kangaroo tail and damper, and we do the dances, Torres Strait Islander and Aboriginal dances, mobile clinic. This is planning, Paha, sorry. This is our Warralong community, so just to give you an idea of some of the work that we do out in the remote communities. So the challenges, as you can see, they're massive, and that's only just some of the challenges. And so, we listen, we do staff surveys every year, and we also do community surveys. So once the feedback that we get from those, we actually look in what can we do. And a lot of the times it's negative and it's running us down, you're not doing your job and everything like that, and that's okay. We never take that stuff personally. We look at, okay, well, what can we do to try and fix it for them, Staff opportunities, we provide lots of incentives for all our staff. A paid Christmas break, 5 days off, paid break, that you don't get when you work for government, because I worked for government for many years and never got that. I had to take annual leave. And then these are just some snapshots of our wellbeing program, where we went to Eco Beach to work with the staff, and they came up with how we're going to work together. So, they did the work around how we're going to implement our values in our organisation. And that's it. So thank you. That belongs.